Hello, and welcome to our webinar this afternoon on deep brain stimulation and LSVT LOUD. And we'll be talking about communication challenges and treatment solutions. So we're delighted to have you join us today. My name is Cynthia Fox, and I will be your presenter for the webinar this afternoon. A few quick things that we'll go through before we get to content. There'll be some logistics. One of those logistics is that there was a handout with the presentation. It was emailed to you prior to the start of the webinar, and it's also in your control panel, your ability to print that as well. If for some reason you still did not get access to the handout and would like a copy of the slides, you can email us after the presentation and we'd be happy to share that with you. After a few logistics, I will dig into the content of the presentation, and we'll save a little bit of time at the end of the hour to address your questions. If there are a lot of questions and we start to run over the 1 hour time, anyone who needs to sign off, please do, but I'll be willing to stay on for a few additional minutes to answer any final questions. Lastly, there'll be a survey that launches when you close out of the webinar. If you have an extra 1 or 2 minutes, it would be great if you could fill that out for us, because we use that information to help us plan future webinars. A little bit about me. I'm a speech language pathologist. I've been with LSVT Global for 25 years now. I am an LSVT LOUD Faculty, LSVT Big Faculty, and I currently serve as CEO for the corporation. And my disclosures include both financial and non-financial. Non-financial relationships include a preference for LSVT LOUD, which is the treatment technique that I will be talking about, mostly this behavioral treatment technique I'll be talking about this afternoon. And I'm also an employee of LSVT Global. I receive lecture honorarium and I have ownership interest in the company. For those of you who are speech language pathologists and would like to self-report this activity for CEUs, you are able to do that. Please know these are not ASHA or state registered CEUs, but they can be used for self-reported credit. So what you'll need to do is, first of all, attend the entire hour of presentation, and then you can email us and request a certificate, and we'll send that to you. That will have your name, the date, and the duration of the webinar. Licensing requirements for CEUs obviously differ by state, so check with your state licensing board and determine if your state accepts non-ASHA registered CEU activities. Okay, so our learning objectives for today are that upon the conclusion of this webinar, we'd like you to be able to describe voice and speech changes following deep brain stimulation surgery. Explain how LSVT LOUD may improve communication post-DBS. Outline some adaptations that we can incorporate in the treatment that can facilitate and potentially optimize positive outcomes. And then highlight some future adaptations, both surgical as well as behavioral, that may have the potential to improve speech post deep brain stimulation surgery. So it will be an exciting 1 hour event. Before we go any further, what I'd like to do is learn just a little bit about who's in my audience today. So I'm launching a poll. Let's see. And sorry, just give me a moment here, and I'm having a little bit of, okay. You can see now the poll, and it'd be great if you can take just a moment to click and vote so we know who is out there participating today. And I'll give just a little bit of time here to allow everyone the opportunity to vote. And it looks like we have some people with Parkinson's disease, about 6%. 88% are speech language pathology professionals, so welcome. And we have also some speech language pathology students. So we welcome you all today. That's good for me to know that we have a lot of professionals, but we also are excited that we have some people with Parkinson's disease who are wanting to learn more about this as well. So let me close the poll and get back to the slides here. Okay, so what is deep brain stimulation surgery? Deep brain stimulation. Many of you may be familiar with this already, but there could be some of you who are new to this topic, which is why you're attending the presentation today. Deep brain stimulation uses a surgically implanted medical device to deliver electrical stimulation to a targeted area in the brain. It electrically stimulates specific structures that control unwanted symptoms. And in our case, these would be symptoms secondary to Parkinson's disease. Deep brain stimulation can be placed in different locations in the brain. And in relation to Parkinson's disease, the most common placements are the subthalamic nucleus or the globus pallidus interna, or internal segment. You see these two schematics on the slide here that were from Parkinson.org showing where the location of these structures are. These are nuclei situated deep in the brain. You see the GPI on the left and the subthalamic nucleus on the right. And these structures are very small, so this is a very targeted surgery that occurs to be able to place these electrodes in these structures in the brain. The deep brain stimulation, the electrodes are then connected to a neurostimulator that is sort of like a pacemaker that's placed under the clavicle. And again, you see that in the schemata here on the picture. Stimulation can be done unilaterally or bilaterally, and it consists of multiple surgeries to both place the electrodes and the stimulators in the process. The candidate selection for DBS takes into account many factors, and it's typically a team of individuals, including the person with Parkinson's disease and the family of the person with Parkinson's disease, to make these decisions. So the neurology team, neurosurgical team, it's ideal that to have the nursing, speech language pathologist, physical occupational therapist, all participating in some of the candidate selection. These are some of the general characteristics that are considered. First of all, that it's a diagnosis of idiopathic Parkinson's disease, and that would be in contrast to a diagnosis of an atypical type of Parkinson's disease, such as multisystem atrophy or progressive supranuclear palsy. That the person has had a robust and sustained response to levodopa medications prior to coming to DBS, and that they currently have substantial motor disability. There's the absence of dementia or unstable neuropsychiatric symptoms. Those can be things that may be exacerbated post-DBS, which is why it's a consideration that not to have those symptoms pre-treatment. An absence of considerable surgical and medical risk factors, which can be wide-ranging. And ultimately, again, individual symptoms, needs, and goals should be considered in target site selection. And again, that would be the target of the subthalamic nucleus or the globus pallidus internal segment. So how does DBS then affect symptoms of Parkinson's disease? Well, it can reduce and or control rigidity, bradykinesia, akinesia, tremor, and dyskinesia. And in fact, many times it's when increased medicine is required to get the best benefit that dyskinesia can be a negative side effect. So following deep brain stimulation surgery, oftentimes people can reduce the amount of medications they're taking, which ultimately can reduce the dyskinesias. It doesn't cure Parkinson's disease. It will return them to the best situation that they've had in their on time on their medication. And that's important to manage expectations of what DBS surgery can and cannot do post LSVT LOUD or post DBS. Stimulation in the STN can lead to depression, apathy, impulsivity, worsened verbal fluency, and executive dysfunction. So these are risk factors. And it has not been effective on gait and balance or postural instability. And as we'll spend quite a bit of time talking about today, speech is another challenge post-DBS. There are some complications that can occur as with any surgical procedure, and certainly with neurosurgical procedures. Some of these are very surgically related in terms of intracranial or intracerebral hemorrhage, ischemic stroke, implantation site infection or seizures. And again, you see these percentages are quite low, but they are risk factors. The two that we'll focus on more here, and that affects what we do as speech-language pathologists, are declines in cognition and longitudinal follow-up have been documented. So with chronic stimulation over time, and a possible decline in speech, gait, and balance. And certainly speech will be the focus of what we talk about today. When we look at these two target sites, the STN versus the GPI, there is evidence about a differential impact on speech. This study was reported in 2008, and it was a multi-center study on deep brain stimulation looking at a reported adverse events at 4 years. And what I've pulled out here in terms of the table are the adverse event of speech difficulties, dysphonia, or dysarthria. And so for our individuals with Parkinson's in the audience, dysphonia would be a voice disorder. Dysarthria is a more complete speech disorder where articulation may be involved as well. And you may hear me use those terms, dysarthria, as a way to describe speech impairments. So in the individuals post-STN, that's in the first column in the chart, you can see that the incidences in mild, moderate, and severe were 2 individuals, 3 individuals, and 4 individuals. In contrast, when we look at the GPI in the next column, we see that only 1 patient in the severe category occurred. And Skoda also summarized that speech function seems to be less compromised under GPI DBS than under STN DBS. Further study is still needed, but more of the focus as we move forward when I talk about DBS will be in relation to DBS of the STN. Researchers have begun to also identify some pre-existing speech factors to consider prior to DBS surgery. And this once again speaks to the importance of the speech-language pathologist being part of the DBS team for pre-surgical speech evaluations and to monitor progress all throughout the process. Alina Tripoliti is a leader in this area of speech and DBS. She's at the University of College London with a big DBS research team and has published extensively in this area. And their team have identified some risk factors, including lower preoperative speech intelligibility and longer disease duration are risk factors for having speech problems post-DBS surgery. Skoda et al. Also reported on some risk factors and indicated that a higher overall motor and speech score on the UPDRS-3, where higher is worse, and pre-existing pattern of articulatory slurring and hastening or acceleration of speech are also risk factors that may indicate speech could be problematic post-deep brain stimulation surgery. So let's talk about some of the voice and speech changes that can occur following DBS. There are many studies out there now that have looked at various elements of speech, from subcomponents of speech production, force components of lip, tongue, jaw, to more speech intelligibility and holistic communication. And so I've summarized some of the take-home messages from that body of literature. First of all, Overall, neurosurgical interventions do not consistently or effectively improve speech in Parkinson's disease. And I think we can all agree there are improvements that need to be made. While some individual components of speech may improve, and this includes things like vocal loudness and sustained phonation, oral force control of the tongue, so again, subcomponents of speech production may improve. Studies that look at overall speech intelligibility consistently show that we don't see the same types of improvements as we do, for example, in limb movement. And the range of speech problems that have been reported post-STM-DBS varies greatly, anywhere from 5% up to 61%. A lot of that is due to reporting, and I think as we go through the presentation, why that varies so much may become more clear. Wertheimer and colleagues reported on speech characteristics post-DBS from the patient perspective. So this was a large survey about speech, and it was to both people with DBS and Parkinson's, and then individuals with Parkinson's disease who have not had DBS surgery. And there were significant differences in severity of perceived speech disturbances between the DBS and non-DBS group. The DBS group reported more severe symptoms and more symptom interference with things such as social interaction and daily experiences related to functional, physical, and emotional issues of having a voice disorder. Overall, low volume or a soft voice was the most common speech symptom, and that's also consistent with acoustic data that have been presented in the literature. And DBS had the greatest adverse impact on slurred speech. And for those of you who are speech pathologists, that should be a red flag right there. As we know, hypokinetic dysarthria is the most common presentation in individuals with Parkinson's disease, which is soft, monotone voice, maybe hoarse, breathy voice quality, and imprecise articulation. So when we start to see things such as slurred speech, that signals to us something is different. Tripoliti and her colleagues as well, over their years of both clinical experience and data they've collected where they've been able to correlate speech symptoms with exact target location of electrodes, have characterized two profiles of speech disorders post-DBS. They have a medial profile and a lateral profile, and these data were presented in the article published in 2017 that's noted on the slide. So the medial profile consists of strained, tight, and continuous phonation, inaccurate articulation, perception of breathy insufficiency. So as a listener, the perception is the person does not have enough air. Dr. Tripoliti sort of characterized it as these individuals are more dystonic in their presentation and unfortunately less responsive to behavioral therapy. So this is an audio sample of an individual post-DBS who fits that medial profile.
I'm freaking Lucy Daniel Jonathan, not necessarily in that order.
What order do you have them?
Dad use the first, only say two. Jonathan is and the second more out. Nine and then we got Lucy.
And how many?
The ten.
Nearly 36.
Yeah, that's right.
Okay, so I think if you are familiar with a typical hypokinetic dysarthria presentation, you can appreciate how different this sounds. Again, tight and strained would be a very accurate description. more impairment and articulation. You may have also perceived, again, this came from our colleagues in London, a little bit of a British accent there. The second profile that they described was lateral. And as you can imagine, medial and lateral are related to where the electrodes are placed, more medial or lateral to the STN structure. So the lateral profile is more monotone, flat intonation, a very fast rate of speech, reduced movement of the lips and tongues, and as Dr. Tripoliti characterized it, more hypokinetic and but responds well to LSVT loud. However, she said some of these individuals may have added fatigue and some apathy, but she aptly said nothing that a good LSVT loud clinician couldn't handle. So let's take a listen of an audio sample of the lateral speech profile.
He made me move out to middle school in September. Luke is 13, enjoys playing football. Everything about football, collecting football cards, reading football magazines. And my daughter is the same. She plays football for Bedford Ladies, girls.
Okay, and that's a little closer to what we're used to hearing more in idiopathic Parkinson disease or pre-surgical, although it still is not maybe a little more severe than what we're used to without surgery. Oops.
Right.
Okay. What happens longitudinally over time with stimulation? And this is an important question because the acute stimulation speech can be very different 1 year, 3 years, 6 years later. This study that was published in 2011 by Tripoliti and colleagues looked at 32 patients with bilateral STN DBS at 1 year. 15 of those individuals, they were also able to follow up at 3 years. They also compared them to individuals who had no surgery. Speech was assessed at baseline, post-DBS 1 month, 6 months, and then 1 and 3 years later. And there was a range of speech assessments that were used. At the 1 year mark, what they noted was that speech intelligibility had deteriorated after DBS in 78% of individuals, in contrast to the marked 50.7% improvement in Parkinson motor symptoms. So this highlights that discrepancy that individuals may have post-DBS where motor symptoms and functioning can be greatly improved while speech may either not be improved or actually deteriorate. Looking at those 15 individuals who they were able to follow out to 3 years, what we see on the x-axis here is time. So baseline, 1 month, 6 month, 1 year, 3 years. And on the y-axis is a measure of speech intelligibility. So this was in a sentence intelligibility test, and the percentage of words that listeners could understand is what you see. So you see at baseline, it was about 78% intelligibility there. And what you see in the tube, the black and the orange line, all of these subjects were on stimulation. The difference between these two lines is the black line is they are on stimulation, off medication, and the more red line is on stimulation, on medication. And what you can see is from 1 month to 6 months with stimulation, speech was pretty stable. But at the 1 year mark and continuing out to the 3 year mark with chronic stimulation, you see increased deterioration in speech intelligibility. So going back to that range of people who have speech disorders post-DBS that I presented previously, that was from 5 to 60%. Those may range widely depending upon how long the person has been under stimulation. So ultimately, there is a whole host of factors that can affect speech outcomes post-DBS. This list isn't all-inclusive, but highlights some key considerations. There are surgical factors. These include things such as contact placement, stimulator settings and the frequency, the voltage, the pulse width. Is it unilateral versus bilateral stimulation? And perhaps as frequency of stimulation increases, is there some spread of that electricity or current to structures that weren't necessarily targeted? Medical considerations include things like Parkinson's disease severity and severity of the speech disorder pre-DBS, as well as medication. And then as we look across studies again, there's methodological considerations when we look at research in the literature. What was the selection and number of subjects in the study? The speech measurement tools that were used, and were they specific speech tools such as acoustic measures, voice handicap index, or was it a more general tool like the speech question on the United Parkinson's Disease Rating Scale? And as I already mentioned, time post-surgery. So this is a complicated presentation, and I think for those of you who may be listening that are experiencing DBS, you can appreciate that. And for those of you who are speech therapists who work with patients post-DBS, you can appreciate this as well. In general, the consensus is that the magnitude and consistency of speech improvements with surgery is not the same as limb improvements, thereby calling upon the field of rehabilitation to offer some solutions to help improve communication post-DBS. Let's shift a little bit now and talk about LSVT LOUD and how it, as a speech treatment, may improve communication post-DBS. Overall, our goal in our speech rehab focus is to help individuals maintain and possibly improve their physical capacities. This may address things such as loudness, voice quality, intelligibility, and rate of speech. We want to maintain vital functions such as swallowing safety. When the voice is severely negatively affected, we want to keep that focus on key functional communication. Recognizing in addition to behavioral treatment, we may need devices or augmentation, and we also may need to address cognitive and language deficits. I think our motto is treat early and treat often for people post deep brain stimulation. For those of you who may be unfamiliar with LSVT LOUD, let me give you a very brief background on the treatment, and then we'll talk about the impact of that treatment post-DBS. So our work is based on 30 years of NIH-funded research and clinical experience. Today we have two protocols. LSVT LOUD is a speech therapy. It's delivered by LSVT LOUD certified speech language pathologist. We have a parallel treatment, LSVT BIG, that is a physical and occupational therapy. I will not be talking about that today. However, the public webinar next month in November will be on deep brain stimulation and LSVT BIG. So if that's of interest to you, I'll have information on the date and time of that webinar at the end of this presentation. This is just a sample of the timeline of our 30+ year journey. Our initial, in the late 1980s, was development of the protocol. This was done at the Lee Silverman Center for Parkinson's Disease in Scottsdale, Arizona. Lee Silverman was a person living with Parkinson's disease, and the treatment has since been named in her honor. This work was led by Dr. Lorraine Ramig, and it set the clinical data that fed the systematic research that's gone on over the years, including 3 randomized controlled trials. And our phase 5 work is really clinical implementation, where now that we have a protocol that's been scientifically validated in the research laboratory, how do we translate that to clinical practice, ensuring that people with Parkinson's disease get the same quality of treatment that was established in the scientific studies. Just to give you a snapshot of what this evidence looks like, and I won't go through this in great detail, but you have the details in the slide. This is samples of our 3 randomized controlled trials. The first trial on the top figure compared 2 treatments, LSVT, which had a voice and respiratory focus, versus a respiratory only. We studied individuals pre, post, 6, 12, and 24 months. And the figure that you see in all of these is looking at decibels of sound pressure level, which is an acoustic measure of loudness, over time. And in the top figure, you see in the blue line, the improvements following LSVT LOUD that were actually maintained above pre-treatment levels 2 years after the initial treatment, compared to the respiratory treatment that had a slight immediate post-treatment improvement, but was not maintained over time. The second randomized controlled trial compared LSVT to untreated individuals with Parkinson's disease, pre, post, and 6 months. Similar graph where we're looking at improvements in loudness during reading. The blue line, you see that improvement in the LSVT group that was maintained at 6 months versus no change in the untreated group. And the last randomized controlled trial with 64 subjects looked at LSVT versus a high effort articulatory treatment versus no treatment, pre, post, and 6 months. Again, we see the LSVT in blue having statistically significant immediate post-treatment improvements that were maintained above pre-treatment levels at 6 months. Not much change in the ARTIC group and no change in the untreated group. The key with these studies is that the designs and controls were very much consistent with what's required for randomized controlled trials, which is the highest level of evidence. And that is, they include things such as the therapy protocols were matched in dosage. They were matched in intensity. They were matched in homework exercises and enthusiasm and belief from the delivering therapist. The data were analyzed by blinded methodology. When treatment tasks were collected, there were no cues to use any therapeutic strategies, and the data were collected by people who did not deliver those treatments. And those are just some of the key things and considerations for quality data. Beyond efficacy, we've also spent a lot of time, numerous studies, over 30, examining distributed effects. These include the impact on things like facial expression, intonation, articulatory acoustics, what happens to the brain. And all of these data have been published and make up our solid scientific foundation. The treatment protocol itself consists of 2 halves. The first half of the treatment on the left-hand side are what we consider our daily exercises. These consist of repetitions of sustained vowels, so long ah, with good quality loudness, high-low ah, so ah, ah, working on loudness and intonation. And maximum functional phrases, these are key phrases each individual says that we practice so they become reminders or cues to use the loud voice in daily speech. The second half of the session is really structured reading and spontaneous speech tasks that build in complexity across the 4 weeks of treatment. So we start with shorter lengths of utterance from words and phrases, gradually building up to sentences, reading, and conversations. So we have more complex type of communication situations. All therapy includes homework exercises and carryover exercises. So we see this first half as really this core amplitude rescaling, and the second half is a translation of that amplitude to functional, salient, individualized speech goals. So with that introduction and what LSVT LOUD is, let's talk about speech treatment post-DBS. Unfortunately, the literature is extraordinarily limited for any speech treatment approach post-DBS. We have 2 publications related to LSVT LOUD. Jennifer Spielman and colleagues published a case series, and Elena Tripoliti and colleagues published a small group design. Before I give you some of those data, let me just play a video for you. That's an example of a woman post-DBS. In the clip, you'll see her 5 years post-DBS and the impact that it's had on her speech. You will then see her after treatment, and she had 16 sessions of gold standard LSVT LOUD treatment, followed by an additional 8 sessions where the therapist added an additional cue of loud and fast. And we'll take a look at her video now.
I knew the chance of slurred speech was great.
Okay.
But I didn't realize that that's what it was going to sound like.
Okay. So really be thinking loud and fast when you're ready.
Oh, my little kitten, how are you? Are you hungry? Hello.
What do you think?
I think that that's the best I've heard my voice in years.
Okay, so that's a nice example of how speech can sound post-DBS when we talk about articulation being impacted and more slurred speech, and the improvements that we can have, not only in loudness, but also articulatory clarity post-treatment. So these are some data from the study done by Spielman and colleagues. On the top is looking at sound pressure level. There were 3 groups. There was a group, 4 people in each group who received, one group received LSVT post-DBS, one group received LSVT but did not have DBS, and one group was untreated. Pre-post 6-month follow-up on the x-axis, again, increases in sound pressure level across a range of tasks on the y-axis. And what we can see in the solid line is the group post-DBS, the dashed line, the LSVT with no DBS, both showing nice improvements in loudness that lasted over time. And then the untreated group. The second graph on the bottom is looking at a measure of articulation, vowel articulation index. An increase in this is an improvement. So if we looked at the dotted line of the untreated, we see no change and a slight deterioration at 6 months. The dashed line on top is the LSVT non-surgical group. And then the solid line showing the LSVT LOUD surgical group with significant improvements post that actually continued to improve out to 6 months. One thing that may be very clear to you is how much more severe the speech of the DBS group was compared to the other 2 groups pre-treatment, and that's consistent with other data we've talked about over time. While the outcomes looked pretty promising, feedback from the 3 clinicians definitely said the speech treatment was harder, that the individuals post-DBS it was harder for them to get the right target phonations and loudness during speech exercises. They had more persistent hoarseness, slurring, and impaired tongue control, and a little more difficulty with carryover into conversational speech. And one possible explanation is that they had very high frequency stimulator settings, which we know works very well for movement, but as negatively impacts speech intelligibility. Moving on to the study published by Dr. Tripoliti and her colleagues, she had 20 participants. Similar in that she had what she called a medical group, which were individuals with Parkinson's disease but no surgery, and then the surgical group, so the post-DBS group. They were measured pre, post, and follow-up. LSVT LOUD was administered and looked at acoustics, speech intelligibility, and perceptual measures. I'll summarize the data that are on this chart. I know the numbers may be a little small on your screen, but basically across these tasks of phonation, which would be long O's, reading, and monologue, the medical group, LSVT with no DBS, showed statistically significant improvements post-treatment and over time, very consistent with the previously published literature. Her DBS group did not show any statistically significant differences for any of these tasks in vocal loudness. There were trends for some improvements, and certainly some improvements were there, but it was not statistically significant. So what Dr. Tripoliti has talked about was that the participants were highly variable in the response to LSVT loud. So some of them actually did respond quite well, some minimally or not at all, which when we lumped them together as a group, the group statistics were not significant. We did a small pilot study following the Spielman study in our laboratory. These data are not published, but they were presented at a poster presentation, and I think they're interesting to share with you here. We had 3 individuals with idiopathic Parkinson's post bilateral DBS STM. They received gold standard 4-week LSVT loud. At the end of that 1 month, they received an additional 2 weeks, 8 sessions of articulation training in loud and clear. Loud and cleared was a regimen designed to augment the LSVT loud effects by providing additional training in high effort oral speech articulation. And again, this is because we see in DBS so much more involvement in articulation and sometimes slurring type speech. Here. This was looking at vocal sound pressure level. This is the measure I keep showing over and over again. It's related to loudness, and the higher up on the graph, the louder the voice. If we look at the first column here with the circle, this is 1 subject post-DBS. You see 3 pre-treatment indications of vocal loudness, 2 immediately post, and then 2 after each of the 2 additional weeks in treatment. So we do see a little bit increase in improvement with the additional treatment, but there's variability in performance. The middle column, the subject DBS 7, same setup, 3 pre, 2 post, 1 data point at the end of each of those 2 additional weeks. Really didn't see a lot of improvement overall, and you can tell by the variability of performance. And then the third individual in that last column, similar to the first, where we see some nice improvements immediately post that are maintained, in some cases maybe slightly augmented at those additional 2 weeks of follow-up. We asked and interviewed the patients about the additional 2 weeks of training and simply asked them, you know, after these 2 additional weeks, do you feel your outcomes are better or the same than they were at the end of the 4 weeks? And you see all 3 felt they were better. They all felt that the additional 2 weeks made their speech clearer. 2 individuals felt that it helped them actually use the strategies outside of treatment. And the DBS 9 had a nice comment. Once loudness was indoctrinated, this allowed me to improve articulation of consonants. 2 of the individuals felt they were repeating less, and 2 of the individuals felt that the addition of the 2 weeks helped them be more clear. These are those same 3 individuals, and this is looking at a measure of communicative effectiveness, so their self-perception of improvement of communication. And we saw, again, nice improvements immediately post that were maintained in DBS 6 and DBS 9 with those 2 additional weeks of treatment. So what are some adaptations that we may consider within LSVT treatment to facilitate positive outcomes? Let me just start by saying what adaptations are. These might be things like increasing repetitions for shorter durations, allowing more rest breaks, persisting at the phrase or sentence level of the hierarchy, utilizing family and support systems for carryover, adding additional sessions, and more frequent follow-up. Those are all ways to facilitate improvements. Adaptations are not altering the core protocol in any way by delivering fewer sessions, shorter sessions, changing treatment tasks, or eliminating any core element of the focus on amplitude, high effort intensive training with sensory recalibration. So in LSVT training, we actually train therapists in great detail about these adaptations. I'll highlight some examples of what those might look like for you this afternoon. We found that we have to spend more time shaping and modeling good voice quality during all exercises post-DBS. We may have to model shorter duration. So even though someone could hold an ah for 15 seconds, we may only do 5 seconds because voice quality deteriorates with increased duration. As I already mentioned, longer rest periods. For the medial speech profile, Dr. Tripoliti has found that it's helpful to break up the sequence of the treatment. And instead of all the long ahs, all the high ahs, low ahs, etc., she does 5 shorter, loud, long ahs, 3 highs, 3 lows, some speaking tasks, and then goes back and repeats. So all of the repetitions are there, but the sequence of providing them is broken up, and she found that sometimes that can be helpful. Focusing on shorter functional phrases for more severe speech impairments, we found that it may take longer for calibration to kick in due to cognitive or learning challenges post-DBS. And there may be some increased frustration due to fatigue, and fatigue is real post-DBS. In general, repetition is so important. Keeping a simple focus, even when other communication deficits are there, what can we focus on and get our best outcomes for? Acknowledging fatigue within the treatment session, validate that it's real, provide longer rest breaks. And if any of you know LSVT, typically in idiopathic, we encourage fatigue because we're really exercising the system and we're building up endurance. Fatigue that we see post-DBS may be very different, and it may actually need a little bit of a break, a little bit of a rest. Scheduling sessions when patients are at their best can also facilitate better outcomes. We may need more frequent and continuous follow-up. We may need more than just LSVT loud. And so once LSVT loud is established, sometimes adding augmentative noise in the ear can help kick in the Lombard effect and may be helpful. The Speech Vibe is one device that does that. More information can be found on their website. Sometimes for fluency issues, speech hesitations, stuttering-like behavior or festination, using altered auditory feedback. And one device is the Speech Easy, and more information can be found about that as well. Using augmentative device supplementation, pacing, either with the alphabet board, tactile cueing, clicking a pen, and as we saw in the video example, additional cues, loud and fast, loud and clear. But ultimately, we say give everyone a chance. So we never turn anybody away from trials just because they present with very severe or complex speech. We encourage individuals with Parkinson's disease to give it a try. Have the clinician do stimulability testing. Try a week of trial treatment and see what can be achieved. Sometimes we are all amazed at the outcomes we can have, and keeping that key focus on functional oral communication, knowing that any kind of oral communication can dramatically improve quality of life, even if supplementation is also required. The multidisciplinary team is key, so as speech therapists, be there, have a seat at that DBS table and speak up and advocate for patients, in particular if they have some of those risk factors. Not that it changes the person with Parkinson's disease's mind about having DBS or not, but they should be fully informed of all the potential complications or risk factors that may happen after DBS surgery. So ultimately, optimizing stimulating setters for speech. This is a team approach with the person with Parkinson's disease, us as speech language pathologists, the neurologist, the neurosurgeon. There are cases where some patients have 2 settings. They have one setting for speech, where they sit down, minimize movement, but either turning off their stimulator or having a speech setting allows them to have better communication. And then a setting for movement. And so maybe speech is not as good, but turn that on and mobility is improved with that setting. So there are things that can be done. And in the future adaptations, adjustments to stimulators may be key. Seek out behavioral speech treatment if you're a person with Parkinson's disease and you're having speech problems with DBS. LSVT LOUD for the 4-week gold standard is what we would recommend. You and your therapist can then decide, do we need more therapy? Do we need to add supplementation with devices? Do we need more frequent follow-up? And for those very severe speech impairments that are more difficult to respond to behavioral treatment, still give it a trial. See if we can get some oral communication, and then entertain the idea of potentially needing augmentative communication devices. So in closing, let's highlight some advances that may improve speech outcomes in the future. These are not surgical advances, but advances to adjustments to stimulators that are becoming available as the technology improves and as we're learning more about this. So one potential adjustment is adaptive DBS. And this is a DBS system that uses feedback from the brain itself to fine-tune its signaling versus constant electric stimulation to brain regions. So traditionally, the stimulation is constant. This is adaptive. In a small study with Trip Little and Trippoliti and colleagues, in the acute testing of adaptive DBS, there was less detrimental effects to speech intelligibility than there was with continuous DBS. So this was considered proof of concept. Certainly more research needs to be done. A study by Dayel et al., also out of the London group, looked at shortening pulse width and found that in individuals, not necessarily with more severe speech, with both more mild speech post-DBS, that there was some improvement when the pulse width of stimulation was shortened. So again, needs further research. Fabry and colleagues looked at low frequency stimulation. And in the last study, it was a combination where they looked at lower frequency, lower pulse width, and a higher voltage setting. You see all of these studies, except the first one, came out this year. These are new things that are happening in the pipeline. All of these studies were in, I would call it an experimental setting. So let's come in, let's adjust stimulator settings, let's measure speech output. They didn't necessarily leave these settings and then look at changes long term. That obviously is a next step after this kind of proof of concept has been established. And then with behavioral treatment, Dr. Trippoliti now pre-treats patients with LSVT LOUD before DBS surgery. And according to her quote, she said, with LSVT pre, we have had great improvements. She is working on collecting data and writing it up. So she says the scientific evidence still needs to follow, but her clinical impression is that for individuals who have speech problems or at greater risk for potential speech problems post-DBS, treating them pre-DBS with LSVT LOUD is a very good way to go. And one other consideration is the idea of voice banking pre-DBS. So if a person with Parkinson's disease is concerned, there are abilities, and I've put Vocal ID, which is a company that does amazing work, not just for Parkinson's, but for any type of neurological or communication impairment, where the voice, your own voice, can be banked. And if ever a need should arise for augmentative communicative devices, that your voice is there and can be used. The other way, and that can be scary to think about, but a positive way to think about voice banking, if you're doing LSVT LOUD pre-DBS, it can be a speech hierarchy exercise. Provide your voice, give your voice the gift to others. Vocal ID is always accepting voice banking, and it can be a way to practice your louder voice, provide your voice for others, and then just know if ever you need it, that voice is preserved there for you. So in summary, voice and speech changes can occur following DBS. Behavioral speech treatment, such as LSVT LOUD, may improve communication post-DBS. Adaptations can be made that may help facilitate and optimize those outcomes. And there's some exciting future research on adaptations to surgery, stimulation parameters, or timing of behavioral treatment that have a real possibility of improving speech outcomes. So we have some time now, about 5 minutes for some questions. If you'd like to ask a question, the most efficient way to do that is to type your question into the chat box on your panel. You can also raise your hand and we can unmute your microphone to ask a question. That tends to be a little more problematic, but we can give it a try. Or if you have any question that you think of that we can't get to today, or you think of after the presentation is over, you can email those at any time to webinars@lsvtglobal.com. So while I give you a moment or two to type in questions, let me just remind you of next month's public webinar. As I mentioned, is Deep Brain Stimulation and LSVT Big, Mobility Challenges and Treatment Solutions. That will be on Wednesday, November 13th from 2 to 3 p.m. And we will be back to Eastern Standard Time versus Daylight Time, which we are on now. Okay, so let me open up our question panel here. And the question is there a specific intelligibility test that is a best assessment and reassessment of speech pre-DBS than after placement? That's a great question. I would turn to some of the tests that have been done in the literature, in particular because you've got a comparator to look at your outcomes compared to somebody else's. The speech intelligibility test, sentence intelligibility test that Dr. Tripoliti uses can be a good one. I would shy away from anything that's a single word intelligibility test. As we know, many people with Parkinson's disease ceiling out because at a single word level in a testing environment, they can score perfectly, even though in connected speech, intelligibility is not as good. One other consideration that may be more for a research level of speech intelligibility than clinical level is looking at speech intelligibility in noise. And there's some nice studies coming out soon that from our lab looking at the impact of different types of speech treatment with an articulation focus versus loudness focus, not just in quiet, but the impact of background noise, which is where a lot of people with Parkinson's disease spend their day talking, either at restaurants or community events. And so how does speech treatment affect speech intelligibility in those maybe more ecologically valid communication situations? Okay, it looks like that may be our only question that we have. Again, if you have more questions afterwards you'd like to send in, please feel free to do so. If you are a professional and you would like a certificate, please email webinars and request that. If you need to sign out, you can do so now. I see that I have one more question that I will try to answer before we close. And the influence of STN DBS versus GBI seems to be an important variable comment. Absolutely. And I don't know that we know the answer why STN is so much more vulnerable for speech problems than a GPI. But the reason why from a holistic person, the GPI or STN would be chosen is looking at all factors. So that includes mobility, balance, gait, pre-factors, duration of disease. The STN is a much smaller structure. If you go back to the anatomical slides in the presentation, and there is one idea that because it's small and the electrodes are the same size, there may be more risk for spread of current to areas that weren't necessarily intended with the stimulation, and that may be one reason why we see more speech impairment post-STN than we do GPI. Okay, thank you for your great questions. Thank you for your participation. I hope you join us next week, and I hope you have a very good rest of your day.